Hello, the topic of this presentation will be an introduction to the measurement of angle of deviation. We already discussed in the previous presentation how to evaluate the muscle balance. We discussed what is normal and what is abnormal muscle balance, what are the grades of muscle imbalance, how can we detect muscle imbalance, how can we document these abnormalities, and the last question that we have to answer is how to measure the degree of muscle imbalance if present. Measurement of the angle of deviation is an integral part in the motor evaluation and in evaluation of patients with strabismus, as it influences the decision of surgery. In order to understand how to measure the angle of deviation, we need to know what are the units for measurement, how do we measure the muscle imbalance, what are the positions of gaze to measure the muscle imbalance in, and how are you going to document these abnormalities. So what is the unit for measuring the angle of deviation? The angle of deviation in strabismus can be measured in one of two units, the degrees and the prism diopters. Degrees are easy to understand. It assumes that each globe has a center. The deviation of the eye in degrees simply represents how many geometrical degrees has the eye rotated along its axis. A prism diopter is a bit different and much complicated than degrees. Suppose you draw a line perpendicular to the center of the eye, and you extended this line so that it intersects a horizontal ruler placed at a distance of 1 meter from the center of rotation of the eye. Now as the eye rotates, the line will move along the ruler. One prism diopter means that the eye rotated so that the line has moved exactly 1 centimeter along the ruler. The relationship between degrees and prism diopters is not linear. In the first degrees, each increase in a degree will result in an almost proportionate increase in prism diopters. However, with larger degrees, the increase in prism diopters grows up infinitely. So for degrees less than 45, each degree is almost equal to 2 prism diopters. But above 45 degrees, the increase in prism diopters is much greater. Before discussing how to measure the angle of deviation, we need to know a brief description of prisms and their optical principles, as they will be widely used in the following talk in measuring the angle of deviation. Prisms are made of plastic or glass. Each prism has a number on it that indicates the power of the prism. Most prisms are calibrated in prism diopters. In few instances, you can find prisms calibrated in degrees. Prisms are triangular in cross-section. Each prism thus has an apex and a base. Prisms may be supplied as separate or loose prisms, in which each prism has a number on it that indicates the power of the prism. Prisms are also available as prism bars, where separate prisms are placed one above the other to make it handy in examination. Prism bars are available as horizontal prisms so that each prism in the bar has an apex to one side and the base to the other side to measure horizontal deviation. And vertical prisms, where prisms are placed with the base down and the apex above to measure vertical deviations. So how do prisms work? Prisms refract light rays passing through them towards the base of the prism. So imagine if an eye is looking at an object through a prism. The light rays passing through the prism will be refracted towards the base. As the direction of the light entering the eye has changed, the eye will assume that the image is shifted towards the apex of the prism. So while the actual bending of light rays is towards the base, the image will be shifted towards the apex of the prism. So how are prisms held? As a general rule, to measure the angle of deviation, prisms must be placed with the base opposite to the deviation, or in other words, the apex should point towards the deviation. So in a patient with esotropia, the prism will be placed with the base outside and the apex inside. A patient with exotropia, the prism will be placed with the base inward and the apex outward. In a patient with a vertical deviation, the prism is placed with the apex of the prism pointing to the position of the eye, so it should be placed base down, apex up in front of the hypertropic eye, and base up, apex down in front of the hypotropic eye. In general, prisms are placed to neutralize the deviation. We start with smaller prisms and gradually increase the prism power. If we reach the largest prism power on the prism bar, you can use a separate prism of a larger power. So after we have had a brief introduction to prisms, the question is, how can we measure the angle of deviation? Tests used to measure the angle of deviation include the corneal reflex methods, the cover tests, and the dissociative tests. In clinical practice, the corneal reflex methods and the cover tests are the most widely used. The corneal reflex tests include the Hirshberg test, the Krimsky, the modified Krimsky, the parameter, and the major amploscope or the synoptophore. The Hirshberg test is the most basic test to measure the angle of deviation. It is based on the assumption that when we hold a flash of light in front of a person, the reflex of the light on the cornea should be on the center of the pupil of both eyes if the eyes are straight or orthotropic. If the eye deviates, the light reflex will shift from the center of the pupil. Each 1 mm of decentration of the light reflex from the center of the pupil corresponds to about 7 degrees of deviation. So simply, if the corneal reflex falls on the edge of the pupil, the angle is 15 degrees. If it falls on the iris, the angle is 30 degrees. And if it falls on the limbus, the angle is 45 degrees. These are examples of esotropia with the corneal reflex being central in the left eye and displaced temporally in the right eye, indicating that there is esotropia of the right eye. As the corneal reflex is on the edge of the pupil, the angle is about 15 degrees. Here the corneal reflex is on the iris, so the angle is 30 degrees. The corneal reflex is at the limbus, so the angle is about 45 degrees. And here the corneal reflex is on the sclera, so the angle is even more than 45 degrees. In exotropia, it is quite similar, except that the corneal reflex is displaced nasally. In this patient, the corneal reflex is at the edge of the pupil, so the angle is 15 degrees. The corneal reflex is here on the iris, so the angle is 30 degrees. Here the corneal reflex is at the limbus, so the angle is 45 degrees. And in this patient, the light reflex is on the sclera, indicating that the angle is even more than 45 degrees. In hypertropia, the eye is deviated up and the corneal reflex is displaced inferiorly, while in hypotropia, the eye is deviated down and the corneal reflex is displaced superiorly. The Hirshberg method is a crude method, and variability in the measurement might occur because of differences in the pupil size. The Krimsky and the modified Krimsky methods are more accurate corneal reflex methods. They allow more accurate measurement of the angle of deviation using prisms. In the Krimsky method, a fixation light is held approximately 33 cm from the patient. Successively increasing prisms are placed before the deviating eye until the corneal reflex is in the center. In this exotropic patient, the corneal reflex is not on the center of the pupil. So when we place a prism of small power with the base inward and the apex outward, that is, out toward the deviation, the prism will shift the image outwards and the light reflex will approach the center of the pupil. We gradually increase the prism power until we reach the correct power. Once we have the correct prism power, the corneal reflex will be on the center of the pupil. This is a patient with left exotropia. We are holding a fixation light approximately 33 cm from the patient. You notice that the corneal reflex is not in the center of the pupil of the left eye, but rather on the nasal part of the iris. We place a base-in prism in front of the exotropic eye. The prism will gradually shift the light reflex towards the apex of the prism, that is towards the pupil center. You gradually increase the prism power, and as you increase the prism power, the corneal reflex approaches the center of the pupil. With the correct prism power, the corneal reflex will be in the center of the pupil and symmetrical between both eyes. The other way is the modified Krimsky test. In the modified Krimsky test, the prisms are placed before the fixating or the straight eye. It has an advantage that it avoids parallax error in observation and allows easier judgment of the centration of the corneal reflex. So how does the modified Krimsky test work? This is a patient with a right exotropia. In the Krimsky test, we placed a prism base-in front of the right or exotropic eye. In the modified Krimsky test, we place the same prism base-in, but this time in front of the fixing or the left eye. The base-in prism will shift the image of the object towards the apex, that is, to the left. Now the left or the fixing eye will have to move to the left in order to regain fixation. According to the Herring law, the right eye will also have to move to the left by exactly the same amount. We gradually increase the prism power, and as you increase the prism power, the left eye will have to move out more, and the right eye will also have to move in more. At the correct prism power, the corneal reflex will be in the center of the pupil of both eyes. This is a patient with a left exotropia. The corneal reflex is on the nasal part of the left iris. We place a prism base-in front of the right eye, which is the fixing eye. The base-in prism will shift the light to the right side of the patient or temporarily. So the right eye will move to the right, and hence the left eye will also move to the right. You gradually increase the prism power until the corneal reflex is in the center of the pupil of both eyes. The prism power is equal to the angle of deviation. If the angle is too large, the larger prism power won't be able to bring the light reflex in the center of the pupils of both eyes, so you need to place a prism in front of both eyes. However, the details of measurements of large angles will be discussed in a separate presentation. There are other corneal reflex tests used to measure the angle of deviation, but they are far less commonly used clinically. They include the perimeter method. In the perimeter method, the patient sits in the middle of the perimeter arc. The patient fixes on a mark on the center of the perimeter. If the patient has a strabismus, the corneal reflex won't be in the center of the deviating eye. Without the patient moving his eyes, the examiner will move the light along the perimeter arc until the corneal reflex is central in the deviating eye. The angle of deviation is measured on the arc. The major amplioscope or synoptophore can also be used to measure the angle of deviation. In fact, the synoptophore can measure the angle of deviation in many different ways. One of them is the corneal reflex. We will discuss the synoptophore later in a separate presentation, but for now, let us note that the synoptophore has two illuminated tubes. You can see the reflected light reflex of the illuminated tubes on the corneas of the patient. The tubes can be angulated until the light reflex is on the center of the pupil of both eyes. The angle can be read directly from the synoptophore. The main disadvantages of the corneal reflex test is that they measure only the manifest deviation or the tropia and neglect the masked part of the deviation, for example the foveas and the intermittent deviations. Therefore, they cannot be used to measure the angle of deviations in intermittent squint. In addition, as most patients have a small latent deviation superimposed on top of the manifest deviation, the corneal reflex test will only measure the manifest part and thus underestimate the angle of deviation. In addition, the corneal reflex tests depend on the corneal reflex and not the eye movement, thus they are more rough and less accurate. Also, we have to know that even in an orthotropic person, the corneal reflex is not necessarily in the center of the pupil. This is because an angle, called angle alpha, present between the fixation axis and the center of the pupil. Let us assume that we divided the eye into two equal nasal and temporal halves with a straight line. This straight line is known as the optical axis. One would assume that the fovea should fall on this axis. However, the fovea is not on the optical axis. On the contrary, it is shifted temporally by a very short distance. So in order for the image to fall on the fovea, the eye will have to rotate the cornea temporally to bring the fovea back to the center. This small temporal rotation is called angle alpha. Normally it is very small and can be hardly seen in clinical examination. However, patients with large hypermetropia might have a larger angle because of the short axial length. This will cause the angle to appear much larger. This is a patient with apparent divergent strabismus due to a large angle alpha. You can see that the corneal reflex is not in the center, but rather shifted nasally. But still there is no movement on cover-uncover tests, indicating that the visual axes of both eyes are well aligned. In such case, if you relied on the corneal reflex, you might wrongly diagnose the patient as divergent squint. The opposite occurs in patients with very high myopia. The temporal retina starts to grow more than the nasal retina, and sometimes a posterior staphyloma might even result, with a resultant shift of the fovea nasal to the optical axis. Now this time, the eyeball would have to rotate the cornea nasally to bring the fovea to the center. This is a patient with high myopia. You can notice that the corneal reflex is shifted temporally, as if the patient has a convergent strabismus. However, on cover-uncover and on alternating cover test, no movement is seen, indicating that this is an apparent convergent strabismus. In such cases, if you relied on the corneal reflex, you might get an error in measurement. The second type of tests that you can use to measure the angle of deviation are the prism and cover tests. The prism and cover tests are the cornerstone for measurement of the angle of deviation in most cases. In the prism and cover test, successively increasing prisms are placed before the deviating eye. The fixating eye is then covered, and any movement of the uncovered eye is noticed. You gradually increase the prism power until there is no movement of the uncovered eye. At the point of neutralization or no movement, the prism power. The prism and cover tests include the simultaneous prism and cover test, and the more important one, which is the prism and the alternating cover test. We will start with the simultaneous prism and cover test. This is a patient with a right exotropia. If you cover the left or the fixating eye, the right eye will move to the center to regain fixation. Now we place a base-in prism of small power in front of the right eye. The prism will shift the image temporally, slightly. Now when you cover the left or fixing eye, the right eye will move nasally, but this time to a smaller amount. The prism power is then increased until you reach the correct power. Once the prism power is correct, the prism will shift the target exactly to the fovea of the right eye. Now when you cover the left eye, there will be no movement of the right eye. If you further increase the prism power, the prism will shift the image more temporally, beyond the fixation axis. Now when you cover the left eye, the right eye will now move from in, out, to regain fixation. This is a patient with left exotropia. When you cover the right eye, the left eye will move from out in. We place the base-in prism in front of the deviating or left eye, and we simultaneously cover the right eye at the same time. You notice that there is still a small movement of the left eye from out in. We gradually increase the prism power, and you can notice that the movement decreases until we reach the correct prism power. At the correct prism power, there is no movement of the left eye uncovering the right eye. The prism in the alternating cover test is similar to the simultaneous prism uncover, but instead of just covering and uncovering the eye, we do an alternating cover test by moving the cover from one eye to the other. We start by placing a prism of small power in front of one eye. The small prism power will shift the image slightly temporarily. Now when we do the alternating cover test, the eye will move from out in, but to a smaller amount. We gradually increase the prism power until we reach the correct prism power. The correct prism power will shift the image exactly to the center of the fovea. Now when we do the alternating cover test, the eye does not move. If we further increase the prism power, the prism will shift the image further temporarily. Now when we do the alternating cover test, the eye will move from in out. This is a patient with esotropia. The eye moves from in out on cover test. Now we have to place a prism base out to shift the image inward toward the deviation. We gradually increase the prism power until there is no movement of the eye on cover test. At the correct prism power, you can see that there is no movement of the eye. If we further increase the prism power, the eye will now move from outside in, indicating some kind of overcorrection. Sometimes the angle is too large, so that the movement does not stop, even with the largest prism on the prism bar. In this patient with exotropia, the eye is moving from out in on cover test. So now we have to place a base-in prism in front of one eye, and we do the alternating cover test. The eye is still moving from out in, so we gradually increase the prism power until the movement stops. You can notice that the movement is decreasing as we increase the prism power. But even with the largest prism in the prism bar, there is still movement of the eye from out in. So you need to place a prism of larger power. Usually a separate prism of larger power is available. At the correct prism power, there is no movement of the eye. Sometimes the angle is too large, so the movement does not stop even with the largest single prism. You notice in this patient there is still large movement of the eye from out in when using the largest prism on the prism bar, or even when using the largest single prism. So now you have to put prisms in front of both eyes. Remember that you have to put the prisms both base in because the patient is exotropic. You gradually increase the power of the prism until the movement stops. As we approach the neutral point, the movement is decreasing until you reach the correct prism power where there is no movement on alternating cover test. Now, if we further increase the prism power, you notice that the movement will reverse from inside out, indicating that you exceeded the neutral point. Remember that during measurement of the angle, you need to start with a small prism power, and you gradually increase the prism power. You notice that as you increase the prism power, the movement becomes less and less. You can also ask the patient, is the object moving or not? If he says that the object is moving, this is why. They also depend on the eye movement, not the corneal reflex, so they are more accurate as they avoid errors due to abnormalities in angle alpha. The cover test can also measure the secondary angle of deviation in paralytic and restrictive strabismus, but we are going to discuss this in a separate presentation later on. The cover tests, however, require a cooperative patient with proper attention, so in a patient like this, it will be hard to use. In addition, they require center fixation, therefore they cannot be used in eccentric fixations or in blind eyes. The objective tests that we discussed in this presentation, which are the corneal reflex methods and the cover tests, are the main cornerstone for the measurement of angle of deviation. The other type of tests, which are the dissociative or the subjective tests, will be discussed later in a separate presentation. So now that we know the test to measure the angle of deviation, what are the positions of gaze where we need to test? The angle of deviation has to be measured with any of the aforementioned tests in the primary position for distance with and without glasses and for near with and without glasses. Sometimes we need also to measure the angle for near with a +3 diopter lens placed in front of the glasses. In addition, the angle of deviation should be measured in up gaze and in down gaze, in right gaze and in left gaze, and in right head tilt and left head tilt. These measurements are usually done for distance with the patient wearing his glasses. This is an example to summarize how we are going to measure the angle. We start with the distance without glasses. Then for near using an accommodative target without glasses. Then for distance with the glasses on. And then for near using an accommodative target with the glasses on. And then in down gaze using a chin up position, and in up gaze using a chin down position. Then we measure the angle in right gaze by turning the face to the left, and in left gaze by turning the face to the right. Remember, in measuring the angle in side gazes, try to avoid placing the prism before the abducting eye to minimize the error. It's much better to place the prism in front of the adducting eye. So finally, how are you going to document these abnormalities? The angle of deviation is written down in the tic-tac-toe plot, which have 9 spaces to allow writing the angle of deviation in each position of gaze. The angle of deviation is measured in the primary position, at first for distance with glasses. This is the most important angle and is usually written in the center square of the tic-tac-toe plot. Then for the distance without glasses, for near without glasses, for near with glasses, and for near with glasses after adding a +3 diopter lens. The angle is then measured in the up gaze and in down gaze, and then in side gazes, and it is documented in the tic-tac-toe plot. Thank you.